Welcome all to the TB Think Tank Special Edition webinar. This session is titled The Assessment of Routine DSTB Data, Access, Usage and Quality in 3 South African Provinces. The DAART-TB project forms part of the DSI task team's work, which is also known as the Data Systems and Innovations task team, and links directly to efforts to strengthen TB services. This work was undertaken to help inform the development of the EMR system. And as a TB think tank, we are grateful to the Stellenbosch University team as well as the HISP team for their work. So a brief introduction to today's speaker. Hanli Myberg is a social behavioral researcher with over a decade of experience studying HIV and TB programs in Southern Africa. Her early work in a PEPFAR-funded NGO and an HIV-focused master's shaped her interest in how relational dynamics influence service delivery and access. She has led evaluations of health information systems, including Tier.net, for both ART and TB services in the Cape Winelands district. Since joining the Desmond Tutu TB Center at Stellenbosch University in 2015, she has led qualitative and mixed methods research across multiple HIV and implementation science projects. She completed her PhD in anthropology at the University of Amsterdam in 2025, this year, using ethnographic research within the pop art trial. Her work consistently aims to apply ethnographic insight to strengthen health services and inform equitable program design in low and middle income settings. Over to you, Hanli.
Thank you, Nolwazi, and thanks everyone. Let me switch on my camera. Thanks everyone for joining this afternoon. Let me share my slides and then I'll share with you about the project and our findings. Okay. So as Nolwazi said, I'll be presenting on the assessment of routine drug susceptible or DSTB data access, usage and quality in 3 South African provinces. We've acronymed it as DAART-TB. And as Nolwazi said, this work has been conducted by myself and other colleagues from the Desmond Tutu TB Center at Stellenbosch University, also with our partners, the Health Information Systems Program of South Africa, who are quite directly involved in supporting the DHIS system, the District Health Information System in South Africa. So our session plan for the day is, you can just briefly see it here: project background, aims and objectives, methods. I'll start by giving some of our key findings and messages from the work just to pique your interest, and then I'll go into more of a deep dive into the results from the different activities we conducted, and then end off with key recommendations for impact. So the DAART-TB project developed in response to a request from the TB think tank on behalf of the National Department of Health for an evaluation of current DSTB data access, quality, usage, as well as the flows of these data across different health systems tiers in South Africa. The initial work was meant to do a pre and a post assessment of the new TB EMR, but this was since revised to really focus into a comprehensive view of the current systems in terms of access, usage and quality, to really inform the development of an electronic medical record system for TB. And as I said, we led this project very much in close collaboration with the TB think tank and HISP SA. The project was funded by the Bill and Melinda Gates Foundation. And so I want to situate the project in terms of the crossroads we are at now in terms of how drug susceptible TB data are managed. So this isn't going to be much of a comprehensive overview. So I'm hoping members of the audience have a bit of background to our health information systems in South Africa. I know there's a lot of acronyms as well, but we can always go through these at the end of the presentation. So over the past 2 decades, so more than 20 years, there have really been major shifts in drug-susceptible TB information management in South Africa. We went from a fully paper-based, let me just put on my laser pointer, from a fully paper-based nurse-managed system to electronic platforms such as the ETR.net and TIA.net, which required capturing by data clerks or capturers. And this has really expanded the access to DSTB data and also decentralized data entry to clerks away from nurses. And so these reforms really brought TB closer to the digitized integrated models that have been pioneered by the HIV and the ART program, and which has improved accessibility across health system levels. So as you can see here with TIA.net, goes all the way up, and your web DHIS system, which is then meant to be reporting to your national indicator data set. But these gains have remained constrained. So the system has evolved within rigid inherited structures that limit space to design a fit for a purpose DSTB information system. Instead of streamlined, patient-centered and efficient processes, facilities are contending with multiple registers, duplicative entries and complex workflows that often drain time and also still fail to generate reliable TB data. And so as South Africa is preparing for our national health insurance, our NHI, and an integrated electronic health record or electronic medical record, the country faces a critical choice. We can continue to elaborate on and maneuver within the constraints of the current inherited unfit for purpose systems, or we can take the opportunity to really purposefully redesign the DSTB data systems with a vision for the future. And so in the DAART-TB project, we aim to assess current routine DSTB data in terms of data access, usage, and quality. Our objectives were to describe the current guidelines, so the ideal for DSTB data management at national, provincial, sub-district, and district and facility levels, to describe DSTB data access, quality, and usage across these levels, including barriers and facilitators in the current TB data system. So really to see what's happening in practice. And then to evaluate the concordance of aggregate level data at facility and sub-district levels as it's exported from TIA.net to web DHIS, and including also our monthly data indicators, which are not currently being captured in TIA.net, with the aim to make recommendations for improving access, quality, usage, to design a fit-for-purpose system, especially in view of the EMR that is being rolled out in some places currently as well. So I'll briefly go over our methods before going into the results. So the aim was to document standard procedures and practices that guide DSTB data management, to map the data flows of DSTB data, and then to assess access, usage, and quality. And so to achieve these objectives, we conducted 4 types of data collection activities. Our timeline was October 2024 until June 2025 this year. Let me go to the next slide. So as part of our formative research, we wanted to understand the ideal processes for DSTB data management. So what should be happening if you look at our policies and our guidelines? And so we identified and reviewed current policies, guidelines, and standard operating procedures or SOPs that guide DSTB data management. We mapped data sources, flows, responsibilities, and timing as per the guidelines. So that, again, the ideal. And we source these documents through online platforms, Housing Department of Health policies, guidelines, and SOPs, as well as through email communication with strategic health information managers. And second, we conducted facility-based assessments to understand what is happening in practice at facility level. So our assessments aim to map DHIS-TB data sources, flow, responsibilities, and timing in practice. This included mapping the presumptive TB pathway, so presumptive meaning those screening and testing data, the data sources being used, so from TB screening to testing, as well as how DHIS-TB data from source registers and folders are entered into tier.net and web DHIS. We also explored data access and usage at facility level, looking at which data sources and registers are used or accessed by whom, for what purpose, and to describe how these data are being collated, reviewed, verified, and reported in upwards data flows. We also assessed the agreement between TB identification registers and tier.net. I'll go explain a bit more about these registers in a moment. So comparing specifically the number of TB positive cases in the TB ID registers and tier.net. So all those cases should typically be in tier.net for the period of October to December 2024. Our facility-based assessments were a month long. I'll go into the setting just now for where these were conducted. And we conducted observations of the presumptive TB data pathway, the semi-structured interviews with health facility staff, and then, as I said, the comparison of the TB ID registers with tier. So for these assessments, we included one district from each province. So we included KwaZulu-Natal, Gauteng, and Eastern Cape provinces, and purposefully selected one health district in each province. In each of these provinces and the districts included, we selected 4 facilities. This was done in consultation with a TB think tank, with provincial TB managers, and we looked at annual TB caseload, facility types, so for example, hospital, community health centers, clinics, and in context, so really looking at getting a few facilities that were really urban in context versus rural facilities. So this purpose of selection was really aimed at achieving a diverse sample. We also added an additional facility in the Eastern Cape province. We purposefully excluded the Western Cape because the province has multiple data systems. It's primarily digitized, and it's not really representative of the rest of the country. We also conducted key informant interviews with Department of Health staff involved in multiple levels of the health system, so national, provincial, district, sub-district, and as I also said, facility level, to really understand the experiences of accessing, using, and of the quality of DHIS-TB data at these different levels. We identified the individuals through provincial and district managers and the national TB cluster. We conducted these interviews via telephone or using online platforms, and all participants had more than 10 years of experience in TB, HAST, which is HIV/AIDS, STI, and TB program, or in health information systems. And some cases, the participants had experience in 2 of these programs. HISP SA conducted a concordance assessment. So we say quality, but it's a concordance assessment. So based on agreement between elements found in tier.net and web DHIS, and also for monthly DHIS-TB data elements from those source registers or documents and web DHIS, using a rapid internal performance data audit. So it's in short called a RIPDA tool. And they also conducted a usage assessment of DHIS-TB quarterly data elements within DHIS2, which is the same as web DHIS, focusing on user access to visualizations and dashboards across the 3 provinces, and also focusing on the districts and sub-districts involved. So these are the DHIS-TB presumptive data elements, also the monthly. and the outcomes or the quarterly data elements that are the focus of the concordance assessments between source registers or tier.net and Web DHIS. These elements are also the focus of our facility-based assessments in terms of understanding data sources, flows, aggregation, entry, and reporting. We collaboratively identified and agreed upon these elements between DTTC, HISP, and the think tank. So before we get into the details, I'd like to start with a quick overview of the main findings, as I said before, and key takeaways that emerged from these activities. So the first was, let me just bring it up there. So the SOPs, the standard operating procedures guiding both TB and HIV data and patient management, were really unclear and difficult to understand. This is from our review that we did, which I'll go into more detail in a moment. The District Health Management Information Systems policy and the standard operating procedure that go alongside it do not fully integrate TB and HIV processes and data management alongside other routine primary care data. And so one of our key kind of takeaways or messages is that these policies and SOPs should be revised and aligned to reflect an integrated data management with that of TB and by default with HIV data as well. At facility level, we also found that DSTB data management processes are complex and onerous. It involves multiple registers, electronic systems, data pathways that really are difficult to navigate for staff at facility level, in addition to delivering quality care. And it really, in many ways, sets facilities and staff up for failure. So these really need to be streamlined and drastically simplified at facility level to really enable staff to more easily capture and use and report their data at facility level. The TB ID registers or identification registers are poorly maintained and captured, and monthly DSTB source input forms are similarly poorly completed, verified, and entered into Web DHIS. This was really key areas of concern. And so we are recommending to discontinue these registers and the input forms and revise the presumptive DSTB data elements that are being recorded at health facility level. So really look which ones do we absolutely need for NIDS reporting, what can be automated and digitized directly from our National Health Laboratory Service, so the NHLS here. Just have one more slide before I'll go into the deeper findings. So we also found substantive gaps in TB folder completion. This has been reported always, you know, if you look at TB and HIV data, but there are gaps in how folders are completed, how those folders are captured, and even the data pathways that ultimately take the folder to being captured. So we recommend that an electronic treatment record for DSTB should be digitized and implemented, which will strengthen patient management and also the reporting of the outcomes data for DSTB, which the folder is a source for. A central issue for health information and program managers across the different health system tiers was a lack or limited access to real-time DSTB data, which hampered their data use and also the use of data for program management. So health information systems should be implemented that enable access to real-time data across all health system tiers and levels of staff. So I'll now go through the data that inform the main findings and key messages in detail. This is the order in which they will be presented. So I'll start first with a review of existing policies, guidelines, and SOPs. So this is the ideal. Now, I just want to stress that what I'll be sharing now, it's not including any data collected with people. It's just a desktop review of policies. But it really is quite important to understand what processes should be happening. And then in point 2, we'll start going into what's actually happening in practice, as well as data access and use across the different health system tiers. And then lastly, look at data quality or concordance. In the green block here at the bottom right, you can see the ethics and the national, provincial, and district approval processes that were followed and obtained, including access to data. Okay, so I'll be spending a bit of time on this, as I said. So this is really a process of mapping what should happen ideally at facility level and upwards with regard to DSTB data management, as stipulated in the official guidelines and standard operating procedures. So we identified 8 documents that were released by the National Department of Health that inform current management of primary care, health information, and DSTB data specifically. So in this presentation, I'm focusing mostly on primary care levels, even though we also include 4 hospitals in our analysis. That will be reported more fully in the report that accompanies this presentation. So we grouped and color-coded these 8 documents into 3 focus areas to cumulatively map primary healthcare service organization in blue, what you see here, your routine health information for district health information systems reporting in pink, and then our routine DSTB data management, which is in green, onto each other. So you can see the accompanying documents with each of these. As I said, we're focusing on primary care in this presentation. So this is a simplified model. It doesn't maybe look so simplified here, but this is a simplified model of the contact points between primary care clients in different care streams. So you can see your blue is chronic, green is maternal, mother and child and sexual reproductive health, and your orange here is acute. And the source registers for web DHIS reporting. And then at the bottom, you can see routine DSTB data that's mapped onto that. So I will now zoom into the primary care data sources and flows that go into web DHIS. So again, this is what should be happening in practice, so the ideal. So you can see I've just removed the TB data. So the key contact points with clients and where data are collected that are relevant to this assessment include the reception and client registration. So here, clients should be registered on the electronic health patient registration system, so HPRS, and their attendance should also be recorded on the reception headcount register. So that's a paper-based system, and that should be HPRS as an e-register. The reception should also be the central location for storing, retrieving, and filing all client folders. So next, clients typically move to the vital sign station and or the consultation room, depending how your facilities are set up. So here, these are the spaces where clients are screened for infectious and non-communicable diseases and then clinically evaluated or assessed. So in primary care, all primary healthcare services and screenings are recorded on your primary healthcare comprehensive tick register. I'll just show you a quick example of what that looks like. So this is a standardized paper-based register used to record specific health services provided for each client visit. It serves to track attendances for specific conditions, services, and treatments like the ones we saw before: maternal and child health, reproductive health, and disease-specific services. Only 2, let me just bring that up, only 2 DSTB or TB data elements are recorded on the tick register. This is screen for TB under 5 and screen for TB over 5. You can see here highlighted in red. So aggregated data from these tick registers are verified and entered into web DHIS daily or weekly for monitoring and evaluating primary care delivery, and also for your NIDS reporting. So you can see, I know this is very small, but there you have all the different service areas, and TB only has those 2 on there. So both the reception headcount register and your primary care comprehensive tick register are tallied week or daily or weekly, and they should be verified by the facility manager before being captured into web DHIS by a designated data capturer. So that's it for now, just for your, this is from your district health management information systems facility level policy, and also drawing on the integrated primary care management. So now if we move on to your DSTB data, these data sources for Web DHIS specifically are incorporated alongside your routine primary care data as per your integrated TB HIV data management SOP from 2019. So the DSTB data elements are collected from two source registers. So this is your presumptive or your DSTB monthly data. So the two registers involved here are your PHC comprehensive tick register, which I just showed you with the two screening data elements. And then clients with TB symptoms or risk factors require a TB test. And as soon as that happens, they are entered into your TB identification register, which is also paper-based. Let me just see if I have that picture here. So here's an example of a TB identification register. The comprehensive data that are being filled in here, it records details of all individuals tested for TB, including their patient demographics, which I've blanked out here, your risk factors for during your screen. It also includes your testing dates, your test types, and your results, your eligibility for treatment, and then your treatment start is recorded here. The TPT, a TB preventive therapy treatment start, has also recently been added. And so alongside your primary healthcare tick register, the TB ID register is the source of all the other monthly or presumptive DSTB data elements that are reported on. And so for your quarterly DSTB data or your outcomes data, the source is your TB treatment record or the blue TB treatment folder. And that gets captured daily or weekly, supposed to be daily, onto tier.net. And then there's an export that happens from from tier.net, which then gets imported into Web DHIS on a quarterly basis. I'll now be going into this process in a little bit more detail in the following figure. So again, this is the ideal flow of both the monthly and the quarterly DSTB data elements, but I think it's important for us to understand the detail and just the complexity that is involved in here. So these processes serve the National Indicator Data Set reporting, so the NIDS reporting requirement on the left. So this figure that I've drawn up here illustrates the following. So TB screening is ticked on the primary care comprehensive tick register. This is happening daily. Aggregated totals are then entered onto Web DHIS daily with your other primary care data. All other DSTB monthly data, including your TB testing, your confirmed diagnosis, and your treatment start, must be recorded on your TB ID register. So by the 5th of each month, all presumptive DSTB data, which make up your monthly DSTB data elements, must be aggregated from your tick register and your ID registers onto a monthly data input form. That's what the MDI stands for here. Here's an example of your MDI form. So the MDI form is 5 pages long. These are just excerpts from the form. And here you can see TB monthly data, they're your T screening data elements, and here are all the other TB monthly data elements, your DSTB monthly data elements that are recorded or transcribed onto this form. There's then a data quality check that needs to happen by the facility manager. And then this form is what is the source for capturing manually into Web DHIS. When we then go on to our quarterly data elements, so there's one source for this, and that is your treatment record, which, as I've said before, must be captured onto tier.net. And then on a quarterly basis, there should be a tier.net export that goes to sub-district level, where it is then joined with all the other exports from the other facilities. It's verified and then imported into Web DHIS, and then it's available automatically, as Web DHIS is of course cloud-based. So on the right, you can see the national reporting timelines, including the dates of each month that data must be signed off for review by the next year up. So for facility level, it's the 5th. At sub-district level, it's the 10th, 15th for district, and so onwards. So this is just for NIDS reporting. There's also an operational element to your DSTB data elements, which is a separate process, which I just briefly want to show you. And so I try to capture it here. So this is where your tier.net system comes in, which, as you know, was very much meant to be a patient management system, initially used for HIV, but later on there was a DSTB module included. And so this is really for your operational purposes, so for patient management. So in addition to this process that has to happen, your TB ID registers must also be captured onto tier.net. This should be happening on a daily and weekly weekly basis, depending on how this facility is set up. And this process is similar. The DSTB quarterly data, those purposes, the TB treatment record should be captured. This kind of is the same as this process. So it's really additionally the TB ID registers that need to be captured also into tier.net, and the routine capturing of your treatment records serves the dual purpose of being able to report your DSTB quarterly outcomes data, but also to have those outcomes reports, your loss to follow-up reports for patient management, for your patient recalls and things like that, that you can directly access at facility level on tier.net. Okay, so if we just summarize briefly what this shows. So we find that our TB and our HIV programs continue to reflect historical siloed approaches. As you know, especially HIV has been a siloed program. TB similarly has been quite disconnected from other programs. And this was evident in our SOP documentation, where our district health management information system policy and the SOP doesn't really integrate your TB HIV processes. For that, there's a whole separate SOP, which is your TB HIV management SOPs, which comes in 2 parts, one for facility level and one for sub-district level and up. And so it doesn't really reflect a fully harmonized framework for TB HIV data management within your broader primary healthcare data processes. The SOPs that guide both your TB HIV data and patient management are also somewhat unclear, and the operational TB data needs for patient management via tier was not sufficiently distinct from the national reporting pathway via Web DHIS. This is if you look closely in that patient or in the actual SOP for TB HIV data management. So this could potentially lead to data quality issues. There are disjointed data sources and capture points for DSTB. And for presumptive TB data, which is reported monthly, 2 data elements are sourced from your TIC registers. Other elements are collected through your ID registers, and then your treatment outcome data, which is reported quarterly, is captured from the TB treatment record. So these data sources are recorded and reported through different channels and timeframes, as I hope you could follow from the figures I showed, which can introduce a lot of variability in the data definitions and undermine the consistency and reliability of these data, especially when it's consolidated into Web DHIS. So now in the next section, I just showed you what should be happening ideally in practice, and I'll now give a brief overview of what we found in practice based on our facility-based assessments. So we worked in 9 primary healthcare facilities and 4 hospitals using facility-based assessments to map the flow of routine health information from your DSTB monthly and quarterly data elements relevant to the projects, of those specific elements. And then we compared what we actually saw in facilities to what was documented in the SOPs. So as I said before, we're focusing predominantly on the primary care facilities in this presentation. And so I'll zoom into these areas briefly. You can see the figure here. It basically shows what the guidance says, and then in each of these contact points, what key deviations were in red. So I'll first start with reception and patient registration area. So some things to highlight with the reception and patient registration. So the guidance outlines that there should be a single admin point and that clients should be registered on the health patient registration system and also be recorded in the headcount register, which is paper-based, and that these registers should be tallied daily, weekly, monthly. In practice, we found that there was typically a single admin point available. People were consistently using reception headcount registers. And facilities also use summary sheets for these headcount registers to tally and verify these data. So this went along with your primary care tick register often. So there were typically good systems in place for that. We found, though, that TB client folders are typically separated from other program folders for the duration that clients are on treatment. We saw that 6 of the 9 primary care facilities used HPRS. Hospitals used variable systems, so SAP, HMS2, or an e-health system. There were really quite consistent network issues across the facilities included, and this compromised the consistent use of HPRS especially and required back capturing. And we also saw disparate folder numbers being used by facilities, even in ones with the HPRS system, and often things like insufficient stationery. So I think just to highlight what this affects is just the kind of a bottleneck during patient registration and things like duplicate folders, which just kind of hamper the streamlined movement of clients through the system. So, of course, this doesn't have a direct impact necessarily on the DSTB data because no DSTB data indicators or elements are, of course, collected here at reception and registration. But when we then move to the vital sign and your consultation room stations, we found that TB screening was consistently recorded on the PHC tick registers. So again, there are that massive flow for primary care data. You have your comprehensive tick register. And so these were tallied quite well. There were good systems in place for that. People also systematically used TB screen, or there were TB screening tools routinely available, and these also prompted for TUT risk factors, but these were not systematically used, however. Then if we look where there were some issues, specifically at these two contact points with clients, both for data, but with clients as well. So facilities had multiple TB ID registers in different rooms or wards, and this really seemed to show quite a few issues in terms of record keeping and tallying, because now these registers need to make their way to be tallied, verified, and then ultimately captured into WebDHIS and DAART.net for the operational purpose. We also found that summary forms for verifying monthly DSTB data, so those monthly data input forms, were not widely available as per the SOP. And so actually being able to map how these data from the TB ID registers and the comprehensive tick registers were being tallied, verified, and then being captured was quite tricky to actually map. And you would often hear different versions of the events or the processes from different staff. When we then look at the capturing into WebDHIS and DAART.net, these were the following key issues. So, as I said, inconsistently used or incomplete TB ID registers, gaps in summarizing or verifying these presumptive TB data from TB ID registers. As I just said, lack of clarity on how to aggregate and verify the monthly DSTB data elements from the source registers. And we also saw inconsistent capturing of TB ID registers into WebDHIS and DAART.net, and also the TB Blue cards. So our key findings here is that there are variable reception and patient registration systems across facilities, which mean often that you have dual paper and electronic systems which are duplicating efforts. You have inconsistent network availability and reliability, which affects service delivery. Most primary care facilities reported frequent or daily network outages. This disrupted their access to HPRS. So also then the ability to actually go and call up those folders for the client standing in front of them, and delaying client registrations and contributing to longer waiting times and administrative backlogs. One Eastern Cape facility had a fully electronic system with computers in all consultation rooms. They were using HMS2. It was actually a primary care facility. This integrated streamlined data recording, tallying, and verification for their primary care data. Not so much for the TB, but because they still had the other systems in place for that. The location and the number of paper-based TB ID registers in a facility also directly affected the capturing, the verification, and the overall management of the DSTB data. So processes were definitely more streamlined in facilities where there was a single centralized TB ID register with someone taking more of responsibility and accountability for that, including the aggregation and verification of those data. And as I said before, we found non-standardized aggregation and verification practices of the monthly DSTB data. So for your presumptive TB data elements. Of course, for quarterly data elements, these are done automatically. It's captured in tier, and then there's an export from tier and an import into Web DHIS. So as I've already said, staff share divergent processes for how these data were tallied, verified, and captured. Staff also shared limited trust in the completeness of tier.net data, which led them to use workarounds for their data needs. So across multiple facilities, there were concerns about incomplete or outdated data in tier.net, which undermined its use for patient management, so the reports that it could draw. As a result, some clinicians developed unofficial workarounds to manage their patient information, such as using A4 notebooks, or what people call sipononos, to manually track patient care, and then continuing also to rely on the phased out TB data, TB diary. These manual tools were used to list TB positive clients and to record details like treatment initiation, appointment dates, and tests conducted, leading to a duplication of data management efforts, because of course this is also what tier.net is able to do. Unlike the TB ID registers, which captures both positive and negative test results, these informal methods, so these diaries that they created, only included the TB positive clients and managing their visits and their care. So there's really that need, which ideally, of course, tier.net is meant to be able to do, but because there weren't always good practices in terms of capturing too few clerks, and a sense that TB data were deprioritized compared to the other data, including for HIV, it created distrust in that system. If we look at data access and use, I'll be drawing also on the facility-based assessments and the key informant interviews with national, provincial, sub-district and district staff, as well as a DHIS2 data usage assessment that HISP conducted to speak to this. So this table, I know it's not the prettiest table, but this table summarizes which systems are typically accessible at each health system tier, who the primary users are, and the data that are available, and then our reported facilitators and barriers to access, which also speak to data use. So I'll just be going into the different levels. Facility, I've joined sub-district with district level, and then provincial and national. So at facility level, the systems that are accessible: TB ID registers, which is your case identification register, your blue TB folders, which is your TB treatment records, the NHLS web portal, which is your lab results, and staff typically also have access to the app on their phones. Then we have tier.net, which is your patient management system, and then Web DHIS, which is used for your routine aggregate reporting. And then if we look at your facilitators and if we look at the facilitators and barriers to access, so there was limited access to tier.net and to Web DHIS beyond your clerks. There's typically poor maintenance of the source registers, especially the TB ID registers, inconsistent capturing from patient records, and then the network disruptions, which I've mentioned before. I think I have a quote here. Just see if I can bring it up. Yeah, so in terms of usage, as I've said before, distrust of data in TIA.net leads to workarounds to track care of TB positive clients. Your TB ID registers record positive and negative TB tests, does not facilitate management of TB positive cases, and then the network issues. So there's a lot of overlap really in terms of the issues. Access and usage is obviously quite intertwined. Next, before I go into the following levels, I want to say that all the non-facility-based participants raised similar issues or concerns around access and use. So all participants from sub-district to national level saw the benefit of access to live facility-level data. They explained that being able to see real-time data would improve their oversight of the facility's performance, their support needs, and also facilitate early intervention. This was opposed to receiving TIA.net dispatches periodically, which obviously is happening at sub-district level, and for provincial and national participants seeing those data only upon sign-off in Web DHIS, and obviously then it's also aggregated. So if we look at the data systems typically available at sub-district and district level, this includes TIA.net, but it's typically read-only and it's local dispatches, your Web DHIS, which is your routine aggregated reporting, and your NHLS dashboards. So they can access patient line data via TIA.net, but it's not live. And then they have access to aggregated DSTB data via Web DHIS. If we look at facilitators and barriers to access and use, this includes no or expired credentials. So people are aware that, you know, they need to reactivate their credentials, but there's often issues with that. Another factor that many managers at these levels mentioned was that their laptops that they have for their personal or for their work personal use is often underpowered to run TIA.net with the multiple dispatches. And so they would still rely mostly on the clerks at sub-district level to access data or to make any queries. And if they really want to have access to real-time data, they'd be going to the facility to actually see what's happening there. On the next slide, I include a few quotes just so that you can see some of these sentiments expressed in people's own words. Yeah, we have a sub-district participant saying, I don't really use DHIS. They pulled that from TIA.net. TIA is more relevant because it's what DHIS really that which DHIS gives us. By the time I get to the facility, the TIA data has already changed because that's obviously being captured on a daily basis. So that's why they find TIA more relevant. If I can have more regular updated information that's live for the facility, it would assist me to assist them to manage their patients better. Yeah, we have someone from district in Gauteng. I usually use DHIS when it's time for reporting. When I actually want to see what's the problem, I use TIA because TIA shows you what the facility is really doing and how they're capturing their data. Even when we want to check patient management, it is better with TIA because obviously DHIS gives us numbers only. Here, someone is speaking about the various systems that are being used and calling for one integrated software where you can access everything at a single point. And mentioning that it would be important for doing data verification because now you have to check, has this person visited the facility, maybe in HPRS? Did they actually make it in TIA.net? You know, to actually track that kind of cascade of care. If you could have one integrated system, it would make our life much, much better. And just a last quote here, saying the systems are working well, but it depends if everything is captured in TIA.net. So yeah, the person is saying, you know, the systems could work well, but obviously at facility level, we must facilitate or ensure that the data that is being generated are actually making it into the systems. Yeah. Okay, and then if we look at provincial and national levels, the systems typically that are available is your Web DHIS and your NHLS. And so they access aggregated DSTB data and are limited to integrate those data mostly. And so they also similarly emphasize the value of accessing line data for their work and the value of an integrated DSTB data system. So in these two quotes you can see here, they would have liked to have access to line data, with a provincial person saying we need to run quality checks at provincial level, but we are limited because we rely on facilities to do them. And then you see an outcome only when we upload it on Web DHIS. So being able to kind of intervene earlier by being able to have more oversight of what's happening at facility level would be helpful. And here you even have someone at national level saying they'd like to see their facilities, how they are performing. It doesn't have to be, including patient details. It can be anonymized. But once it goes into DHIS, they're saying there's nothing much I can do. And in the next slide, I'll share insights from the DHIS2 usage report, which was prepared by HISP. It's available as a full report, which also goes along with the full report on this work, technical report that we've submitted with the think tank. And so in this usage assessment, they looked at the access to DSTB data visualizations and dashboards in the districts and provinces included in our assessment. And the period of assessment was from April 2024 to March 2025. And so I just include a few highlights from the reports. We found that the existing visualizations and reports available in DHIS2, which is Web DHIS, just in case for those who are wondering, were significantly underutilized. So out of almost 4,000 active users in DHIS2, only about 20% access TB visualizations. It was an average of just 23 views per user per quarter. And so user access by job function indicated that data capturers access reports the most, followed by users with an M&E function, followed by your information managers, facility managers, and program managers. While clinicians, sub-district managers, and your district managers were far fewer in number and their usage were low. The use of the DHIS2 TB dashboards also varied widely across the provinces. So you can see KZN, KwaZulu-Natal had the highest engagement, while your Eastern Cape province had the lowest. And you might be wondering, how does this compare to data usage of these dashboards across other provinces, programs? But compared to other programs, TB reports were used far less frequently than other programs. So users viewed reports across all programs between 98 and 350 times per quarter on average, compared to our 23 views per quarter on average for TB. And so what do we make of these findings? So firstly, the need for real-time facility level data. So your sub-district, district, provincial, and national participants stressed the value of live access to facility level data to improve oversight, verify data, and respond to performance issues in real time. So it's that whole idea of being actively involved versus being more passive, more of an observer to the data you receive. So in the same vein, so the data delays, according to the national reporting timeline, really then limits people's ability to action or to be more active. So your reliance on your monthly and your quarterly TA.net dispatches and post sign-off DHIS data restricts timely intervention and limits participants' ability to influence patient management or correct data issues that they might be lower down in the system. Fragmented systems also hinder visibility. So There was some frustration with having to consult multiple systems to track patients or verify data, and there were calls for integrated interoperable platforms, so a strong demand for a single integrated system that enables cross-facility client tracing, synchronizes your NHLS lab results, and streamlines reporting and verification. We also saw significant data capturing and reporting challenges. In about 1/3 of the facilities, data capturing processes were significantly constrained due to too few data capturers relative to workload, low prioritization of TB data compared to HIV and other primary care data. Also, the complexity of DSTB data entry, including those diagnostic codes and test types. We also saw a misalignment between the M&E and the operational reporting needs. If you think back to that early figure I showed with your NIDS reporting and then your operational reporting or use for patient management rather. So TB data dashboards and in DHIS2 are designated or designed, primarily for M&E reporting, where TB treatment outcomes are reported 12 months after case finding. But your program managers actually require operational data within 6 to 9 months to close cases without outcomes. And this misalignment significantly reduces the perceived relevance of TB dashboards for day-to-day program management. They also found a preference for alternative reporting tools. So many users may prefer exporting data into tools such as Excel and Power BI rather than interacting directly with the DHIS2 dashboards. And some may even rely on TIA.NET reports due to reporting delays, obviously in Web DHIS. And so there's the need for system redesign to meet multi-level user needs. So the systems must balance national M&E and reporting requirements with real-time operational data needs at facility and district levels. So these serve different but complementary purposes. And as I've shown, they are quite complex, the processes in place at facility level. So those ultimately need to be streamlined. Lastly, I'll be presenting on the data quality assessment or the concordance assessment. So this was conducted by HISP. So I'm just sharing quite limited findings from this, as it's not my area of expertise, but we do have the full report available. I'm also not sure if anyone from HISP is on the call. There might be, also for the Q&A later. So to determine data quality, we firstly assessed the concordance between the DSTB sources for monthly and quarterly data. So that is your monthly data input forms and TIA.NET, respectively, and DHIS2. So RIPDA, the Rapid Internal Performance Data Audit tool, was used to assess this concordance. Secondly, we also compared the positive cases between the TB ID registers and TIA.NET at facility level. So that's what we did alongside our facility-based assessments. We also collected qualitative data to contextualize the quantitative assessments, but we'll not be reporting on that in the presentation today. So I'm starting just with the process for the concordance assessments for the quarterly data elements. So that is the comparison between the data found in TIA.NET and in Web DHIS or DHIS2. And so for the quarterly treatment start data elements, the period is Q2 to Q4 or April to December 2024. For the quarterly HIV and ART data elements, the period is Q1 to Q4 2024. And for your quarterly TB outcome data elements, which we know is reported a year later, the period of assessment is Q1 to Q3, so January to September of 2023. So reports on the TB data in TIA.NET databases were received from the relevant sub-districts and facilities in the Eastern Cape and KZN provinces. The quarterly data elements from Gauteng province were not available to us at the time for analysis, unfortunately. So these reports were drawn on the same day, so there was quite a lot of coordination involved. These reports were drawn from the TIA.NET databases at the sub-district and facility on the same day for each of the facilities. This was to ensure that any updates the facility might have made would not reflect on the sub-district database, as we wanted to determine if there were significant differences between the data captured in real time at the facilities and that which was imported into the sub-district databases. So now after this, I'm just briefly telling you what the process was for the concordance assessment between them for the monthly data elements, and then I'll go into the findings from these assessments. So for the monthly DHIS-TB data elements, the period of assessment is Q2 to Q4, April to December of 2024. We only received the monthly data input forms for the full assessment period from one clinic in the Eastern Cape. So as I've said before, facilities had quite variable processes for tallying monthly DHIS-TB data elements. And so we could also see this in terms of the availability of the MDI forms, which were not widely available. Another clinic had only the MDI form for June 2024 available, this also in the Eastern Cape. Others in the Eastern Cape supplied reconciliation forms generated from their databases. So we were able to capture most of the data elements not sourced from the MDI forms, or not sourced from the TIA.NET identification report, from the reconciliation report. Just to make it clear, so in the absence of the MDI forms, we turn to the TIA.NET TB identification report, which is a report generated obviously from TIA.NET, but which is not the source for, or should not be the source for your monthly data, DHIS-TB data. So just to show you again, this is the example of the MDI form, which is the source, but we could not find these at most of the facilities. And so instead, we use the TIA.NET TB ID report. There are quite a few data elements that are not included here. So that is a big limitation of course, of this concordance assessment. Okay, so for both the quarterly and the monthly data, the data from the TIA.NET reports, so those ID reports, the monthly data input forms and the reconciliation forms we received from the provinces, and the data from the DHIS2 report were captured into a RIPTA database. These data were downloaded into Excel spreadsheets, and the deviation between the data in the TIA.NET system and the DHIS2 system was calculated using absolute values. And we graded these deviations according to severity. So 0 to 5 would be not material, and we indicate that with a green font. Above 5 to 15 is material using an amber font, and above 15 is a severe deviation using a red font. So both for the Eastern Cape and the KZN, if we look at the quarterly data elements, so this again is the comparison between data in TIA.NET, those reports, and DHIS2. There were no discrepancies between these data, nor were there there were no discrepancies between the data from the TIA.NET databases at the sub-district and facility, nor were there discrepancies between TIA.NET and DHIS2 for the outcome and the HIV-TB data elements. The tables you see here reflect findings regarding the discrepancies between the two databases for the treatment initiation data element. So the slight deviations that you can see here are most likely due to updates to the data in TIA.NET after the import to DHIS2 was done in April 2025. So the updates will only reflect in DHIS2 when the next import is done in the first week of July 2025. The practice is to import the export files from the TIA.NET databases during the first week of the quarter following the most recently completed quarter. So here you can see there's quite a good concordance. But then if we look at the monthly data elements, This table shows the summary of the deviation between the TB ID report and DHIS2 per data element across all 13 facilities. The deviation between the data elements are all material, save for one data element, this one, the DSTB clinically diagnosed 5 years and older. And those are quite severe deviations. If we look at this by province, so here we have KZN, Gauteng, and Eastern Cape, we similarly see the deviation between the data elements on tier.net, the ID report, and those captured in DHIS2 as material. When we aggregate them across all the facilities, only 2 data elements fall within the acceptable limit of less than 5, the 2 data elements here in KZN. So across all the 3 provinces, there were predominantly large deviations. But again, to remind that we are not using the actual source as outlined in the SOP. For a few Eastern Cape facilities where we were able to access the MDI forms, so those monthly data input forms and the reconciliation forms, we also did a comparison between the MDI forms and DHIS2 to see whether that might look better than the data we could get from the TB ID report. And so you can see that the TB screening data shows no deviations. And to remind, these data are recorded in the primary care tick register, where the flow is quite well integrated into your general primary healthcare flow. And so in general, the deviations between your DHIS2 and the source documents are less significant than those between the TB ID report from tier.net and DHIS2, which might suggest that these source documents may also be used to capture the DHIS2 data elements that were compared with the tier.net report above. So if we just briefly summarize, I mentioned that this would just be a very brief snapshot of these assessments done by HISP. So there were high levels of concordance between tier.net and DHIS2 for the quarterly DSTB outcomes data. And so this indicates that the data transfer process, let me just go back. This indicated that the data transfer processes and the systems involved are functioning effectively, allowing for the accurate reporting of DSTB treatment outcomes and related indicators. I also just want to stress that we did not assess the quality of the data in tier.net in this evaluation, so how complete your outcomes data was in tier.net. So we don't know the quality of the quarterly data, only that the data from tier.net are pulled into WebDHIS properly. And there have been other reports and assessments of those data quality in that way in terms of completement. But then when we look at the monthly DSTB data elements or your presumptive DSTB data, there's significant variability in concordance with these elements, which rely on those paper-based or mixed, the paper and electronic data collection methods. So the deviations range from material to severe, indicating really serious concerns regarding data integrity. So last, I want to just show the comparison of the TB ID registers with tier.net. And so this we conducted at the facilities involved. This was only done again for Gauteng province and Eastern Cape province, as we added this after we'd already finished KZN. And so the period of assessment is October to December 2024. The aim of this assessment was to evaluate the linkage between the TB ID registers and tier.net. So of course here we've got, to identify challenges and opportunities in the maintenance and usage of your ID registers and tier. Agreement between these two data sources indicate potential gaps in the pathway from your presumptive TB clients from a positive screen to TB testing, and then obviously your treatment initiation, which is the point at which you are entered into tier.net for continued management. So the table here shows the number of TB ID registers in use at each facility, the aggregated number of TB positive cases in the TB ID registers per facilities, and then the number of clients recorded in TIA.net as having started on TB treatment, along with the number of matched cases in the TB ID registers and TIA.net. So we also look at where the discrepancies lay with the TB ID registers or with TIA.net, which I'll go over just now in the next slide. So we found that most of the primary care facilities had 1 or 2 TB ID registers in use. 3 of the Gauteng facilities had the highest number of registers in use, with 3, 5, and 9. This was for 2 hospitals and a CHC, respectively. None of the facilities showed full alignment between their TB ID registers and TIA.net. And to remind, ideally, the cases identified in your TB ID register should be captured on TIA.net as having started treatment, or either as having transferred out in your ID register. In all but 1 facility, TIA.net recorded more treatment initiations than were listed as testing positive for TB in the TB ID registers. And across all facilities, there were cases missed in both the registers and in TIA.net. So this is the last slide. So just to say here that some of our insights after having reviewed the reasons for some of these discrepancies. So as I've said before, the TB ID registers were not optimally completed. When we looked more closely, we could see that your test result and your TB treatment start date were the most common incomplete fields. Also, the totals row at the bottom of each register's page was inconsistently completed, and that's really where you're tallying the numbers on that page, which later gets tallied in the overall summary sheet that's at the end of the register, which should then go onto your monthly data input form and be tallied in that way. So the summary sheet and the totals rows were also typically not completed. TB registers for your community outreach most often did not have treatment start dates recorded, but likely due to clients being referred to facilities to start treatment after having tested positive in the community. In a hospital, we also found 1 TB ID register that was used in casualty had no test results or treatment start date recorded for clients. So just that clients had been tested. We found cases of duplicate clients in the TB registers as well in some cases. So that is just in terms of understanding what's happening in the registers themselves. If we look at inconsistencies between the TB ID registers and TIA.net, we found numerous patients in the ID registers, but not in TIA.net. And again, numerous patients recorded in TIA.net as starting treatment, but not in the ID register. Of course, one reason for this discrepancy can be that they've been referrals. So someone has tested at one facility and they are referred for treatment after they've already been diagnosed, which would mean that they would just be captured directly into TIA.net. We also found that some clients who had treatment start dates in the TB ID register, but were transferred out to another facility, were frequently not found in TIA. So, and in one case, we noted a death in the register that was also not recorded in TIA.net. So just to wrap up the key findings from our data quality review. So there were high levels of concordance between TIA.net and DHIS2 for the quarterly DSTB data outcomes data. I'm not going to go into that too much now again. And there's significant variability and concordance with the monthly DSTB data elements, which we have also gone into details. Significantly more discordance in the monthly data elements for the under 5 age group is also something we saw compared to the over 5 age group. And then our TB ID registers, which is a key source document, are not optimally completed, verified, and captured. So lastly, I'm just going to run through some recommendations for impact so that we have time for questions and discussion. So as I see there's also some comments in the chat. Okay, so as I've said before when we started this presentation. So the current monthly DHIS-TB recording and reporting processes are overly complex, burdensome for facilities, and also yield unreliable data. And digitizing these could simplify data collation. The screening elements already flow quite reliably from your primary care comprehensive tick register to web DHIS, and this should remain. But by contrast, TB ID registers are poorly maintained, inconsistently captured into web DHIS and DAART.net, and don't really serve a purpose beyond reporting, making them a major source of missed or inaccurate data. In practice, clinicians must first record patient details at testing, then manually update those results once they've received them, often across multiple registers kept by different staff in different parts of the facility. And this duplication is inefficient and unreliable. And so we therefore recommend that the TB ID registers and the associated monthly data input forms are discontinued in favor of a digitized system for data collection and management. As I've said before, it would be good if facility staff could only capture data that cannot be automated, and they should ideally capture that in real time so that it reduces duplication and free up their time for patient care. Next, a recommendation is to revise and align the policies and SOPs to reflect integrated data management. As I've said, there's very little information in the policy relating to TB and HIV data, except for saying that these data need to be managed according to their respective SOPs. So following the development of simplified, streamlined processes for DHIS-TB data management, or just TB and HIV data management overall at facility level, the DHMIS policy and SOP should be reviewed and updated to reflect this integrated nature of these data with primary care and with web DHIS. So they should eliminate siloed references in existing documents and clearly define TB HIV data as part of routine primary healthcare services data with unified reporting standards. Patient tracking and linkage to care should also be automated. So the DHIS-TB health information system should be designed to automatically update with your NHLS results and allow reports at facility level to flag patients with positive test results who remain unlinked to care. So, for example, something like a TB treatment action list. An integrated, interoperable system across facilities should indicate if and where treatment initiation has occurred. So that would, of course, require interoperable, interlinked systems, and treatment initiation should be captured in real time to reduce the need for follow-up. So facilities should only be required to act on cases that remain unlinked to care, and there should really be clear responsibilities for follow-up across facilities to prevent overburdening frontline staff. So also, the electronic treatment record for TB should be digitized to strengthen that patient management and reporting on treatment outcomes. So we know there are many limitations in DAART.net and that it is being phased out. Of course, that is in one way a digitization of an electronic treatment record, but ideally it should be a system where you can automatically, in real time, capture patient visits as you see those patients. So clinicians need a simple tool to track treatment initiation, return visits, sputums due, and outcomes. The current systems are being undermined by too few clerks, and of course, with the current state of US funding and NGO support dwindling, this is becoming all the more important. There's also the low prioritization of TB data, so it often gets left for last, incomplete stationery, which forces reliance on paper-based workarounds, which is exactly what we're trying to move away from. A real-time clinicians-entered TB EMR on a tablet, for example, would eliminate secondary data capturing, improve your accuracy, and generate reliable reports and line lists for patient management. It should also be built to interoperate with NHLS, and the system should then automatically update with these lab results to ensure timely sputum monitoring and reduce that administrative burden. Managers and and coordinated across health information management and HAST and TB consistently emphasized the critical need for real-time facility level data to support patient management and validate reporting. So these outdated periodic data dispatches obscure visibility, delay intervention, and shift an unreasonable burden onto facilities to get everything right. It is therefore essential to design and implement systems that provide real-time access to data at facility level, that provide real-time access to facility level data, let me say it like that. So this requires minimizing reliance on monthly DSTB dispatches and post-sign-off web DHIS reporting, and instead enabling that automated frequent synchronization of facility level data with central repositories. So ideally, a fully networked system should allow data to be viewed from any tier of the health system, ensuring oversight, accountability, and timely action. And then last, data access control should be improved to ensure the staff responsible for data have reliable credentials and system access. So expand those system credentials beyond data and administrative clerks to include your relevant program managers, coordinators, and data users across levels to avoid sharing of credentials as well, and provide targeted training to ensure stakeholders can interpret, query, and act on facility level TB data effectively. So just a quick snapshot. Together, these recommendations can really aim to transform the DSTB information system from a cumbersome, duplicative, and error-prone set of registers into a streamlined digital real-time platform that better supports facility-level users and national reporting. I'm going to end there just to say thank you and acknowledge all the people that have been part of this work. It has been with all the actors and stakeholders. Of course, this is not possible, and all the people who participated as well from the different provinces and at national level. We really thank you. Thanks.
Thank you so much, Handley. Now time for our question and answer session. Would Zachariah and Pren like to go first? Zachariah and Pren, you're unmuted if you'd like to speak to your comment. Pren? Okay, she's still muted. You can unmute yourself. I've given you permission from my side, as well as Zachariah. In the meantime, is there anyone who would like to ask a question or pose a question rather, or comment?
It seems on my side that some people are muted.
Yes, they're all muted,
and
then I
okay.
manually unmute.
Okay.
Yes. Okay. Any questions then you guys would like to add in the chat box? Well, let's try figure this out. Or maybe perhaps if your colleagues, Handy, would like to say a few words, would like to add a few words. Priya, you may go ahead.
Yeah, firstly, just want to say to Hanley and the team, thank you so much for doing this exquisite piece of work. It was very comprehensive, and that's why we had to even allocate additional time. And I definitely think it was worth it. I think your findings have just kind of silenced everyone because, you know, there's been so much talk around challenges with access to data and the kind of data that you need to, you know, to improve the program. at provincial levels, at district levels. You really unpacked for us with some of your diagrams just how complex and complicated the processes are, and and our expectations on, the data capturers to just manage data. I think for me, the most important thing is that you've highlighted that we assume that it's simple, but it's actually very complex. And for them to, abide by this SOP that by its own nature is, setting them up for failure, it's not surprising that we often query the quality of the data. So, very sobering in terms of just understanding when we develop these systems and when the team that's developing the EMR to try and keep the processes simple, keep it, collect the data that we need only. And yeah, just support the system to be as streamlined as possible. Thank you so much, Hanli. I also know that, making a bold suggestion about the value of the ID registers is, a recommendation that you haven't made lightly, but I'm hoping that we can have further discussions with the department as part of the data systems and innovations task team with yourself as well as the department on, how we move forward on this, because as you've shown, the quality of the data is being compromised by just this additional work. But thank you so much for this comprehensive report, really excellent, and exactly what we were looking for. Thank you, Hanli.
Thank you, Priya.
I have unmuted all participants, so Zakaria or Pren, can you please try again and unmute from your side and go ahead?
Yeah, I know, just a general comment. So thanks, Hanali. Really, really nice piece of work. And I think, plenty of data for us to really absorb and think about where to go next. I mean, it's not the first time that, discrepancies have been pointed out, but I think you've done a very thorough evaluation that really kind of illustrates the complexity we've created in the system, and perhaps unnecessarily so. And I think as a next step, we really need to sit down as a think tank and with the department and actually think about what actions to take based on this, because there's no point in having this fabulous report and then things persist as they currently are. And we really have to figure out how to get better data and to make people's lives easier at the front line. The other comment I made was just a minor issue. I don't think it needs to be reflected again. Thank you.
Thank you so much, Pren. Hando, would you like to respond to her first question or comment, or you're good?
Yeah, no, I'm just happy. Thanks for the kind words. And yeah, I think there are often infrastructural constraints, that bring us also to certain points, but I think it's good to have the detail of the processes and the systems out there so that we can see how can we nudge things. Nudges may be too small, but what are small, big nudges that we can do to really move in the right direction. Yeah.
Thanks, Hanli. Dr. Barry, you can unmute yourself and go ahead. Okay, he might be having challenges with that, but Hanli just asked if the there we go.
I did not know where the mute button was, sorry. No, I wanted to thank Dr. Myberg for the important issue. And then the key area is this data. For those that don't know, I'm working in mining, and we've been trying for a long time to pull the links between the TB and the mining workforce because of silica dust exposure and TB being And it's just been a battle. I've not, I see there are colleagues here from the NDOH, and I'm currently abroad, but we'll try and pick that up in the new year in terms of the integration with NHLS, because we've got a whole lot of TB claims that are not closed because I can't get the NHLS data on the sputum result to close the data. But my question rather is more related to the fact that, is this the data that's used for driving the reporting in terms of drug sensitive TB in the country? So I would be very worried if this is the data that's in the annual reports, the TB strategic plan, etc. And now that we've got the round 7 of the Global Fund, so it's very sobering. So that's more my issue. The other issue about the data linkages, because we've got quite a sophisticated database now for the mining sector and the reporting issues in terms of this. And the big issue that we had is, so the two issues are, one is this data the data that drives the strategic plan and the annual plan? And the second issue is, what about private sector reporting data? Private companies, etc. Or there's the, so how many gold mine picks up a TB diagnosis? Is that coming into this database? Because this was the public sector driven. So I just want to know, because that might be a data gap. Over.
Thank you, Dr. Kistner. Sami, I'm feeling very aware now that I'm the face now at the moment. But yeah, what we presented, these are the data that are reported. Of course, we have a small sample across the country. We have 3 provinces, and we selected a 1 health district in each of those provinces, with only a few facilities in each. We did so to get a diverse kind of perspective of what's happening across different contexts and settings. I'm sure in some places they are better, and these are variable in terms of data management, depending on many different factors. But overall, if you look at the SOPs and the guidelines, those are the requirements for how the data should be recorded and reported and managed, and they are difficult to implement. I think that is unanimously the case, especially when you look at our TB and HIV data processes, which are so separate from our other routinely reported data. So there is really a need to take stock of how do we do this better going forward. I'm not sure if someone from NDOH or Prin or Priya want to add there, perhaps. Yeah.
No, Hande, I think you answered it correctly. Just Dr. Kisnasamy, it didn't include private sector data. So moving on to your second question, this was just the data that we looked at in those select facilities. And it'd be interesting to see, or at least get access to some of the TB in the mines or the mining data to understand how that data is faring. I'm not sure at which point that data enters the National Department of Health data set, if at all it does. But yeah, perhaps we can take that conversation forward. But for now, everything that Hanli has presented has been around the work and the data they've collected in those 3 provinces and the facilities that they've looked at. Thanks, Hanli.
Thanks,
Sorry, Priya, my
Mhm.
initial question is this the data set that's used to drive the strategic plan?
Yes.
Is
So
it the M&E data set? So I know that you took a selection, it's sentinel
yes.
reporting, etc. But what she's pointed out is that it's unreliable. That's the bottom line. I'm being quite blunt here. Computers don't work. There's underpowered computers. People don't change passwords. So I just wanted to clarify that, because I think it's an important indictment in terms of what we are using to drive, the 1 million case finding, etc. So I'm just raising that because I'm not close to the coalface. Sorry, I interrupted, Chair. Just to clarify that, is this the data set that drives the strategic plan?
So if you're asking if this is the data that's being reported, that eventually they use to develop the strategic plan, then the answer is yes. But again, as Hanli has indicated, this was a smaller sample size and it was select facilities in 3 provinces. But yes, this is the exact same data that they would have reported.
Yeah, but obviously for the 5 million campaign, for example, the NHLS data is being used.
Yeah. So Pren is right. Yeah, Pren is right in terms of, to get targets and things like that, they're using the NHLS data. But in terms of the reporting to the National Department of Health, it comes from facilities like these, the small sample.
Thank you, Priya, Pren, and Dr. Barry. Stabiso, are you able to speak to your comment? Dr. Barry, would you like to add on?
No, it was a minor point. What's the feedback loop in the district? I didn't pick up. I picked up the pulling up and the feedback and the problem areas. Is the district making use of the data at the local level to make sense of it? Because it's one thing to push up the ladder. It's a second thing to say, here's intelligent data at district X in those selected districts. Did you query that at all? Because that's a very useful feedback loop to say for next month, lost to follow up or the death case. Yeah, you've made some very interesting observations. What's the use of the data at that facility level or district level if you probe that? Over.
Thanks, Doctor. Yeah, so usually, as I think some of the quotes also showed, so tier.net, if you're at sub-district and district level, there's an access to tier.net often, or at sub-district level, people would actually be going to facilities to go and query and see what is actually happening at facility level if they see specific discrepancies. So that's part of a kind of verification process where, as many of the people at non-facility level explained, follows very much a care cascade approach. So if so many clients were screened, does it make sense that so many have started treatment, so many are lost to follow up? So those numbers should kind of follow a care cascade approach. So that's what one way in which the data would be kind of verified or looked at, and then discrepancies would be sent back to facility level, and in some cases there would be facility visits. So very much when you have an overview of what's happening in your sub-district, there would be targeted interactions with specific facilities in your sub-district, and at a district level, of course, of more of a sub-district level view, and to kind of target your resources and in terms of verification and querying those data that have been reported. Often, I think when you could see, if I can refer back to the quote from the national provincial level, there seems to, especially at that level, be quite a feeling of limitation to actually be able to fix whatever has happened at facility level before. So with the idea that once the data reaches that level, it should be accurate, at least. There shouldn't be such glaring inconsistencies. Yeah, so there are processes in place for that.
Thank you, Hanli. Stabiso, are you able to unmute yourself and speak to your question? Stabiso? Okay, Hanli, Stabiso asked, is there a plan to compile a policy brief to guide monitoring and evaluation to improve the data accuracy and update or replace the paper-based registers?
Thanks. Pren and Priya can also jump in here, but as far as I know, there is a rollout happening of an initial EMR. which is addressing some of these concerns, which I think is quite instrumental to be seeing, what are alternatives to the current practices where they are unnecessarily complex. And then we have presented this to national as well, and we are having quite key discussions with health information management at national level. And in the new year, we'll be having set working group calls to take these further. We have shared the report and the recommendations, but we are very much putting plans in place so that it doesn't go sleep, if I can put it like that. Yeah. Others are welcome to add.
Yeah, so, based on the comment, it's actually just got me thinking that, so clearly some of the discussions with information management at NDOH reflect kind of longer term plans. But, what might be useful as well is to think about some short and intermediate term recommendations for improving current systems. So that might be worth giving some thought to.
Thank you, Pren. We have about 5 minutes left of our session. Any last takers for comments, questions for our presenter today? Any questions, comments? Okay. In the absence of any more questions, if somehow you have any questions or comments after the session, you can email myself and I can put you in touch with Handley, who will answer your questions gladly. And with that, okay, Priya, you can go ahead.
No, just want to let everyone know that we will be loading up this the report on our website for them to access the full detailed report with all Handley's beautiful graphs and flow charts so they can understand, how complex things were, as well as the full data and set of recommendations. Thanks, Nowazi.
Right. Thanks, Priya, for that. So in the absence of any more questions, I'd like to thank our speaker today, Handley. Thank you so much for your time. And thanks to our attendees, of course, for their time as well. And thanks for attending, even if the session was just a tad bit longer. And thanks for your engagement. And we will see you again next week on Monday, where we'll be showcasing the Union Conference presentations Monday at 12 noon. And with that, please do enjoy the rest of your day. Before we go, though, if you'd like to see yourself on this platform, please do email myself at ngosi@tbthinktank.org. With that said, please do enjoy the rest of your day further. Bye.
Thank you, everyone.
Thanks.
Bye.
Bye.